Recording in progress.
ज्वाइन कर लिया तो उसमें
हाँ नॉर्थ साउथ ईस्ट हाँ
Are we there?
Sir, good evening, sir.
Good evening.
Yes. Sir, I will make you co-host.
Okay, thank you. Then I can share my screen. I just want to have a quick check.
Yes, sir. Yes.
Anand, hello.
Yes, ma'am. Good evening, ma'am.
Good evening, Anand. Actually, I need Sir CV.
Ma'am,
Ma'am, just note it. Ma'am, just note it down. Just note it down quickly. 2 sentences.
Yes, sir. Tell me.
Now, I'm a GI surgeon, alumni of SGPGI Lucknow. In practice for the last around 25 years in Punjab, in field practice, non-corporate nursing home based practice for the last around 25 years. And
Okay, sir.
a GI surgeon, and we recently accredited for a training center for ASI, upper GI endoscopy for surgeons,
Okay, sir.
with special interest in safe cholecystectomy. Will that be okay?
Yes, sir.
Thank you. I'm Kawaljit Singh, right?
Yes, sir.
Thank you, ma'am.
Hello, sir. Good evening. Good evening, sir. Hello.
Yeah, who, are you addressing me?
Yeah, Dr.
Yeah.
Monica.
Yeah. Hi. How are you?
I'm fine.
That's great. Can I have a check of my screen share, please?
Yes, sir.
Can I share my screen?
Yes,
Hi,
sir, you
Ajay.
can share. Yes, sir, you can share, sir.
Is it visible?
Yes, sir. It's visible, sir.
Yes, visible. Good evening, Chalu ma'am. Good evening, Anand.
Good evening, Monica.
Good evening, Chalu ma'am. Good evening, Monica
Good-
ma'am.
Good
Hi.
evening. Good evening.
Yes, sir, I can see your skin, sir, and PPTs also, sir.
It's running. The screen is running well.
Yes, sir. It's running, sir.
Thank you so much.
केजे सर फर्स्ट स्लाइड में ही डरा रहे हो आप तो
मेरे को काम ही मुझे weapons का दिया गया है. So I will be focusing upon weapons for surgeons, you know.
Wow.
Hi, good evening. Sadiq here.
Sir, good evening.
Sir,
Good evening, sir.
Good
Anand,
evening,
can
sir.
Hi, good evening. Anand, can I also see whether I can get my screen to, if he removes the gun and the machine is aiming at me?
Yes, sir. Yes, sir. Just give me a 1 minute, sir. KJ,
Okay.
sir, you can stop sharing your screen.
Okay, just give me a moment.
Good evening,
Dr.
everyone.
Shalu, Dr. Monica, Anu,
Good
Sadiq.
evening, sir.
Good evening.
Good evening, sir.
Good
After,
evening, everyone.
after Dr. Sadiq, can I also check my screen
Yes,
sharing,
yes.
please?
We can do before me, Anu, no problem.
Nice, sir, please.
Can I share now?
Sir, wait for a minute, sir. Just wait for a few seconds.
Okay.
Sir, you are co-host now. Now you can share your screen, sir.
We have a lot of colleagues joining from Myanmar. I welcome them. And I hope that we will have more interaction with surgical colleagues in Myanmar.
क्या हो रहा है यार? दिख नहीं रहा कुछ.
अभी नहीं आया. Any of the senior colleagues who have joined, if you want to make any comment in between on any presentation, please feel free to come in and make a comment. Because I may not know everybody by name. I know some familiar names, but
So I have to quit and reopen.
I think you log out and log in. Anu, tab tak aap try karo.
I'll try. I think it's showing.
Yes, ma'am.
Okay, thank you.
TD is there.
Sir, send me a message. He will join, but he
Okay.
have to leave early.
theek hai. That, yes,
Just after finishing the session.
that is fine. That is fine. But Anu, in case TD is held up, because I think he has some other commitment, then I'll request you to chair Dr. Sadiq's presentation, the second one.
Sure, sir.
Yeah. Dr. Paleswan, you can come in so that I can introduce you.
Anu, are you done? You checked?
Yes, sir.
Sir, I did.
Ma'am, done, sir.
It was working. Yes.
Okay, let me try now.
Sadiq, ab aap karo apna share.
Is it coming?
Yes,
Yes, sir. We can see, sir.
Good, good.
Yes, sir, very clear.
Thank you.
We have another 2 minutes. We'll start at 7.
Sir.
Good evening, everyone.
Good evening, Dr. Paleswan. Good evening. Welcome. Thank you very much. Thank you.
And namaste also.
All the participants, Dr. Paleswan Joshi Lakhi is one of the senior most GI surgeons in Nepal. She is very active not only in Nepal, but she comes regularly to the Indian meetings also and in the international meetings. Welcome.
Thank you, sir. Thank you.
Good evening, Dr. Kapoor sir, Dr. Sadiq sir, and Dr. Anu ma'am.
Hi Ajay.
Yeah.
Good evening. Good evening.
Hi Ajay, good evening.
Keep it mute because I am at, hi, good evening, sir. I am at the airport. Hi, good evening, sir. So I am at the airport, so I have to keep it mute on my side.
Okay, okay.
Nice.
तुम कहाँ भाग रहे हो?
On the back airport, sir.
कहीं गया हुआ है अजय शायद.
On the way back to Jaipur, sir. So I'm on the airport. So my flight is after 9, so I can utilize this time. Sir. So if I start speaking, you can hear lots of noises from the back also. So I think it gives a better view now at the airport. I think the dialogue of the entire session would still be what Dr. Sadiq has said yesterday. I think it is not a same ball better removed. It is a safe that we have saved one more bile duct today. I think that should be the baseline now for everybody. We should all follow that. I think I know Dr. Kapoor will second my almost quote Dr. Sadiq daily on the rounds at least once in a day. So we remember you daily, sir, on our rounds here, and all of my students know you equally well now.
Okay, so it's 7. Let's start. Good evening. Welcome, everyone. Welcome to the second master class organized by Jaipur Surgical Tutorial. Those who were not there yesterday, Jaipur Surgical Tutorial is an online education portal which we started at the Mahatma Gandhi Medical College Hospital in Jaipur in the state of Rajasthan in India about 2.5 years ago. And my colleague, Dr. Anand Nagar, has been coordinating all the programming, schedule, and activities of Jaipur Surgical Tutorial. Normally, we do a 1-hour session on Saturday morning, 9 to 10. So those of you who want to join Jaipur Surgical Tutorial, in between, I'll be putting Dr. Anand's contact details. Please send him a WhatsApp message. And then we thought that we might as well start a once in a month masterclass. So last month we started this activity. We did a first masterclass on living donor liver transplant. These are 2-day activities, last Thursday and Friday of a month, 7 to 9 p.m. on 2 days. So 4 hours for each topic. All the JST sessions which have been held so far, as well as the videos of the last masterclass and yesterday's session, they are available on the YouTube channel of Jaipur Surgical Tutorial. I will put that link also in the chat in between. So those who have missed, they can watch it for free on the YouTube channel. And today is the second day of this masterclass on safe cholecystectomy. So we'll continue with the program. And to chair the first presentation, which is by Dr. Kamaljeet Singh, who's a senior consultant GI surgeon in Jalandhar, who's again an alumnus of SCPGI like me and Dr. Sikora and Dr. Ajay. And to chair this session, we have Dr. Shalu Gupta. She is a professor of surgery at the SMS Medical College in Jaipur, and she is also the president of the ASI chapter of Rajasthan, and she's an executive member of the ASI. Welcome, Dr. Shalu. Please start the session.
Thank you, sir. Good evening to all. We are starting today's program with a very important topic. Without port, without instrument, and without energy device, we can't do any surgery. So our today topic is how to handle port, instrument, and energy device by Dr. Kamaljeet Singh. Over to Kamaljeet, sir.
I'm sharing my screen.
Hello?
Yeah, is that okay?
Yeah.
Yes, sir.
Yes, good. Please start.
So good evening, ladies and gentlemen, and my teachers, peers, friends, juniors, and colleagues. And thank you, Dr. Shalu, for the introduction. Dr. Kapoor, thank you so much for this forum. And Dr. Sikora, it's so loud and clear that we've learned what we've learned from you. We are sharing with other people. And I think that is how surgery grows. And without any further ado, I'll just start off. The main dictum of surgery is that you must know your arsenal well. Otherwise, you're going to be in deep trouble. And that is somewhat my edict for today, that ports, instruments, and energy devices. And good evening from Jalandhar. So this is a patient. This site is quite familiar to us GI surgeons. And this, if you see here, there's a large duodenal perforation. It's almost nearly the bend of the D1, D2 gone. And this could not have been anything except a mishap from the cautery. I'll come again, revisit what we need to call cautery. And this is, whether it's a technical complication or a technological complication, is as good your guess as mine. So why are we supposed to be so serious about our arsenal? Why we are so disturbed about it, and why we are so concentrating on this seemingly accessory focus? Now you see, there are 3 big cases with large kind of denominations of the money that has been inflicted upon the surgeon. This is $250,000. This is $2.8 million. This is $10 million. And all these 3 cases are related to a surgical mishap during laparoscopic surgery. And most commonly, the causes in all these 3 cases were energy device related. So knowing how to manage complications is fine, but we are sitting here to avoid them. That's how we avoid our heartache and also the agony to the patient. It's essential to have good tools, but the tools should be also used in the right way. That's our primary thing. So if we see the waves, we're going to have a brief introduction of electrical sciences as should be known by the surgeon. This is the complete spectrum of energy, and our cautery somewhere lies here. What is very important to know is that these are the transmission waves where the current, the energy jumps from one place to another. So you have to be very clear that even in our cautery, the energy can jump from one place to another without any contact. How it will happen, I'll come to very soon. Whenever we buy a weapon, we only see its exterior advantages. But if you see, each weapon has a very dangerous aspect. This applies to surgery as well. And if this dangerous aspect is not known, then we can get into deep, serious trouble during surgery. Now, how do I apply this scenario, the weapon scenario, to my arsenal? If you see the image on the left side, is just an innocuous collection of our instruments. They are harmless when they are kept here, like this, independently. When they are articulated like this, presume this gray thing to be the patient. When they are articulated and assembled like this, when this is going to the cautery unit and this is also going to the cautery unit, then this becomes a very, very dangerous weapon. This becomes an electrical capacitor. I will tell you how. This becomes an electrical capacitor, means that it has, in this part, can hold a lot of energy without your knowledge. And that's where we land into trouble. So a lot of people say there's judicious use of cautery. I at times wonder whether there can ever be a judicious use of cautery. Because why? Because you see, the current not only travels through physical contact, but it jumps to, this is very important to know that the current is not going in a straight line. It jumps from one place to another, and even from sealed parts of active instruments to other organs, which are usually not necessarily near placed to the area of dissection, but they can be placed much far away from the active electrode. So in this background, can the cautery usage be ever judicious? I would rather say cautery is a dangerous weapon, and it can only be used injudiciously, howsoever smart or howsoever careful we may be. How? Let's come to that. So this soldier is out in the battlefield, and in a battle, we need three things: skill set, strategy, and enemy. We need to know what the enemy's skill set is. Now, this is none of my business today. I am going to be focusing upon the weapons. This is the small gamut which I'm going to, adhere to. And this includes ports, instruments, and energy devices, right? So I will be going in a reverse order because this is the most important aspect. So if any slides get skipped, the important part would have been dealt with. Energy devices are of three kinds, which we use in a laparoscopic surgery: cautery, harmonic, and ligashore. I will be limiting myself more to cautery because today's session is primarily on laparoscopic cholecystectomy, and we are using this aspect more. In very specific cases, we use advanced energy devices. This is William Shakespeare, who's known for his adages. Rose by any other name would still smell as sweet. But in science, we need precision. What precision we need? Cautery, whether it can be called cautery or not, cautery is a misnomer. It's not the right term for what we use. The three terms are there: cautery, diathermy, electrosurgical unit. We are limiting ourselves to the correct terminology, and what we use is the electrosurgical unit, short term ESU. So let's be very clear from here on. We should not be using the word cautery. We should be using electrosurgical unit or ESU. Now, electrical surgical unit is a very dangerous weapon. And the more you sweat in peace, the less you will bleed in war. And any surgery is wartime. Surgical education is basically consisting of two things which are mutually independent: to learn to walk the right path and absolutely avoid the wrong path. knowing one does not automatically entitle you to the knowledge of the other. They are two independent things, and we have to ensure that we walk both these things side by side. So besides knowing what to do with the ESU, we ought to refrain from certain things, doing certain things with it. And that's how we are going to use, we are going to avoid disasters. So what exactly are these things which are not to be done? It will be important to know these terms: direct application of the electrode, direct coupling, indirect coupling, insulation failure, capacitive coupling. I'll not confuse you. I'll take you through quick graphic explanation after giving you a brief theory. Now, what is direct application? Direct application is the direct placement of the active surgical electrosurgical electrode over an organ, which may be an organ of your intention, when errors happen, the active electrode may be from bad technique. It may have touched an organ which was not intended to be touched. This happens with premature activation of the active electrode while insertion, which is not to be done. Accidental overshoot, undershoot, slippage of the electrode from the intended point of application, which happens when you are in a hurry, when you are stressed out, when we are not stable, or there is a little chaos. Misidentification of a structure, in which you think a structure is something and then you apply the energy over it, but it's something else. Misjudgment frequently happens in laparoscopic cholecystectomy. Or respiratory movements. In the field, we do, a lot of people are doing lap chole under spinal anesthesia, and respiratory movements are a real problem during spinal anesthesia. During GA, we can handle them. If we are doing a cautery, we can request the anesthetist to just give a pause of apnea, and that can help us in not applying it to a wrong place. Working upon a mobile organ like an ovarian cyst, obviously in tense distended gallbladders also this may be relevant. When the organ slips and keeps moving, then at a particular point of application of energy, it might slip when the organ slips. Momentary lapse or diversion of concentration of the surgeon, very important. You got a mobile call or somebody is shouting from giving you a message, and you are doing the cautery. That's not you're doing the electrosurgical unit application. That's exactly not the way the thing has to be done. It has to be done with full concentration without any diversion, using the active electrode for retraction. So many times we are in a hurry, we coagulate, and then with the same electrode, we do a little bit of retraction. That's not to be done, because inadvertently it can be activated. So direct activation was the direct the current application to an unintended organ. Next is insulation failure. What is insulation failure? We all know that all elective electrodes are covered with a protective insulation sheath. And if you see any kind of laparoscopic surgery instrument which is electrode based, which can be connected to cautery, there's a sheath on this part of the instrument, and only the bare is the distal area, which is the working area, or which is to be in touch with the area of dissection. Now you can see that the only part of the entire instrument that is visible to us is just about 25%. There are 4 parts, 1, 2, 3, and 4. I'll come to that in a while. Only about 1/4 of it is visible to us. And if there is a break in the sheath, any kind of viscera which is coming in near contact, direct contact, or even a little bit distant, this can get a burn. So this is what happens from insulation failure. And as I said, the zones of the instrument, very important to know the instruments: zone 1, 2, and 3, and 4. This, we intend to give current only to the zone 1, but inadvertently during surgery, or when the instruments are not properly maintained or not properly chosen, I'll come to that in a while, the unintended paths can, the current can dissipate from any of these 3 areas, and that's where we get into trouble. So zone 1, 2, 3, and 4, only this part is to be active, but this at times fails. And when this becomes, the current leaks from here, it has been seen that in 18% of cases of disasters, the current had actually leaked from zone 2 of the instrument, which is not in the vision of the surgeon because it's outside of the monitor. and 18% of injuries. It is responsible for 18% of leaks. This area generally has a very small tip. So in cholecystectomy, generally we are very precise, so nothing happens. But this can be responsible for biliovascular injury if, in case, the anatomy is very tight there, and there's a lot of adhesions, and you're doing it without any identification. This can lead to biliovascular injury. This area, zone 3, the most interesting phenomenon is capacitive coupling. Any current leaking from this area can lead to capacitive coupling and major injury to the viscera. That's, I'll come to a little while. Any leakage from zone 4 can give the operating surgeon or the assistant a major current shock, So this also is a very dangerous area. Any cord leak from here, if the cord is there, there's an insulation failure or loose wires are there, the current is, you can get the operating surgeon can get a direct shock from here. So this is what the instrumentation is. Coming to the next phenomenon, which is direct coupling. How does damage happen by direct coupling? Direct coupling is when an active electrode is touching a metallic part. Here, the laparoscope is there, and a viscera comes in contact with this metallic instrument. This may be a laparoscope or a working instrument which is metallic, and a viscera or an organ comes in contact, which is again outside. We are focusing in this area. So this is outside of the view of the surgeon, and you won't even know that an injury has happened. So please keep in your mind the plastic part. I will refer to this in a little while, why this is important to our discussion. So this is what is called direct coupling. The next phenomenon is indirect coupling. Again, a very, very dangerous phenomenon at play during a laparoscopic cholecystectomy. What is it? Due to crowding of instruments during laparoscopic surgery, many times a metallic instrument can come in close confines of an active electrode without even touching it. That's why I said current jumps. So the current will within this distance is supposed to be, should be more than 2 centimeters. Always try not to get any metallic instrument in the vicinity of an active electrode. It should be more than 2 centimeters away, because as you may move near, the chances of a current jumping and conducting it to a distant organ, and this too without contact, this can happen. How it can happen, I'll tell you why. This area is grounded. You see the electrosurgical unit, the path is from the generator to the via the active electrode to the organ, via the patient, and via the earthing pad to the patient, back to the generator. So if the current jumps from this place to this place, this area is earthed, because it's with the patient. There's a short route of the current. So remember always that the current always takes the shortest route. So it jumps first from here to here, and then from this metallic organ to the metallic instrument to this place, and you will not even know that you injured. So this was indirect coupling. The next mechanism, then the most interesting and the most dangerous mechanism of tissue injury during laparoscopic cholecystectomy or any other laparoscopic surgery, is capacitive coupling. Capacitive coupling is that, as I said, when assembled, that thing, the complete assembly forms a capacitor. Now, this is the capacitor. This is the active electrode. This is the insulation sheath. This is the outer metal cannula, and this is the trocar, which may be metal or plastic. Now, let's see if it's plastic. Now, I'm coming to the plastic. I told you to remember why I'll be coming back to it. Let's see, this is plastic. Now, this capacitor accumulates current by inherent tendency of physics. Okay. So what happens is, there is current buildup in this area between the plastic and the active electrode with the intervening sheath, which is insulating sheath. This happens every time. Now, with a poor conductor here, this current is not going to be dissipated because this is not in contact with the skin. This plastic is not in contact with the skin. So this current is not dissipated, and it will take a shortest path with the viscera which is coming in contact, which is grounded. So this is going to cause an injury here. Vis-a-vis, if this is a metallic trocar, now what happens if the current buildup will be there, this capacitive current, will definitely be there, but this is dissipated through the skin. And this danger really is less when metallic trocars are used. So in my concluding slide, I'll come to what is a preference of trocars. Here you see, let me get it to the other side. Here you see again, now this is the area of interest. Everything is fine. The surgeon, this part is under vision. The surgeon is proceeding very comfortably, but he's not knowing that the viscera is in touch with the metal hair. And there are some trocars which for fixation to the skin have a plastic sleeve. Very, very dangerous situation, because again, besides being a metal trocar, the dissipation part with the skin and the subcutaneous tissue is insulated. So again, there is buildup of current here, and an injury can happen to any viscera or organ here. This is capacitive coupling, most important and dangerous phenomenon, which the surgeon will not even come to know what happened.
Only 2-3 more minutes.
I'll have to really skip. Ergonomics, again, ergonomics is very important because we are discussing ports and instruments. Now, there are 3 angles. Ergonomics are very important because of the comfort. For the surgeon, the surgical fatigue is less, and more important, the ease of dissection and the display of structures and anatomy is much better if we honor the principles of ergonomics. Now, 3 angles are there: manipulation angle, azimuth angle, and elevation angle. We must take care of, in the triangulation process of placement of ports, we must take care of these 3 things. And the optimal manipulation angle, that is between the 2 working ports, working instrument, should be around 60. The azimuth angle is the angle between the laparoscope and the working instrument, which should be 30 on either side. Ideally, it should be equal. Elevation angle is the angle of between the working instrument and the plane of the operating organ, which we are operating, which ideally should be 60 degrees. The other thing is the optical axis. I will skip that since I have an important slide to show you. I'll have to skip a few slides. Yeah. Now, this is very important. The electrosurgical unit, we have 2 modes, cut and coagulate. There is little difference between both of them, and you need to understand that the cut is low voltage, high current, and the coagulate is high voltage, low current. The temperatures are very high reached in the coagulation mode. So we always prefer a cut or a blend mode. Very important that the energy setting of the electrosurgical unit generator should be around 50 to 80 watts in the cut mode and 30 to 50 watts in the coagulation mode for it to function optimally without causing any damage. So anytime we generally prefer cut or blend rather than coagulate. If at all we need very, very brief application, I'll come to the concluding slide. Prevention of electrosurgical unit mishaps, caveats. Inspect insulation carefully. Use the lowest possible power setting. Use a low voltage waveform. Use brief intermittent activation instead of just standing on the foot pedal. Hemorrhage or hemostasis is a skill, and cautery is not the answer for that. Cautery means like ESU. Do not activate in open circuit. Open circuit means when the active electrode is outside of the body. Do not activate because the long circuit is there and stray currents are definitely going to damage somewhere the patient. Do not activate in close proximity or direct contact with another instrument. As I said, 2 centimeters is the distance. Prefer all metal cannulas or trocars over hybrid or plastic ones. Very important. We have certain advances in techniques, and these are tissue response generators and active electrode monitoring systems. They are the systems which sense a leakage of current from the electrosurgical unit, and they'll give you a warning that there's a leakage. So stop and check your instruments. Thank you so much, guys. I have absolutely no idea what kind of faith this has on his weapon. So it's very important not to have unrealistic expectations from your weapons. At the same time, don't land up doing harm from the use rather than good, which is intended, our aim. Thank you all for this, for allowing me to present this very important yet ignored topic for laparoscopic surgeons. Thank you.
Dr. Shalu, please.
Sir. Thank you, sir, for a nice presentation. You cover surgical unit very well. And sir, as you told, when we are doing the safe and the judicious use of the electrosurgical unit should be there. Otherwise, the chance of the injury to duodenum and the CVTs are more. And one thing is very important. Usually, whenever there is a bleeding, do not use blindly electrocautery there. It is the most common cause of the CVD injury. So use properly, and port placement is very important. In the many time we so there is a large liver. So we may go for the another port even on the left hypochondrium. So if do you need another port, no problem. You put another port, but do not do any injury to the structures.
Very true. I concur with each and every point what you've made. There's absolutely no debate on that.
Since there are no questions in the chat, maybe I can request other faculty, Dr. Sadiq, Ajay, Dr. TD, to make any comments.
Sir, very good evening, and thanks Dr. Kamaljeet for a lucid presentation. I want to add two important points. One is that duration of the contact. So if you go by the physics of the electrosurgical units, apart from the sitting, if you are having a more contact, means it will be the temperature generated will be much more, and injury can be more than what is expected. That's why you go in a purge, small purge, and then only do the this thing. Setting is very important, and all of us should know the tip temperature of the cautery, which depends on the setting as well as the duration of the contact. Second is the one more important point which we always think that we are always seeing in magnification. So at least twice magnification is there in laparoscopy in comparison to the open. So if you are putting your point of the contact, you are thinking that it is 1 centimeter away, but because you are seeing in a magnification, it might be only 0.5.
Yeah.
So I think these two important issues are also important when we are talking about all these things. Thank you.
Ajay has made a comment. Ajay, if you are there, would you like to elaborate on that? Dr. Ajay Sharma?
Yes, sir. I think when we are using a cautery, using a cautery in a bipolar mode will decrease the current spread. And second thing, similarly, if you're using it in a spray mode, the cautery may be helpful because then it doesn't cause a deep burn to the adjoining structure. So sometimes these two things may be helpful. In between, there was a lot of points people have raised that cautery should not be used in it should be used in a cutting mode. I think I slightly differ from that because often in cutting mode, when you're using a cautery, it may cause a bleed, and in an attempt to control that bleed, you may overburn the tissues. So that is my.
For hemostasis control, I would never suggest a cutting mode. It's a blend mode, which is blend category 3, where there is nearly 50-50 cut, 50 coagulate. Probably that is the best mode, Ajay. You made a very right point. Cut cannot be used for hemostasis achievement. Actual coagulation, even spray is less damaging, but it's much more than the damage which is caused by a blend.
Kamalji, there's a question from Jayant in the chat.
Sure, sir. I'll take the chat questions. Just a moment.
So he says, is it safe to take down the cystic artery with bipolar cautery or harmonic rather than conventional clipping and dividing?
As far as the harmonic is concerned, yes, definitely. I have no experience of using a bipolar, but I agree. People have been using bipolar for cystic artery. But one thing is sure, monopolar not to be used for cystic artery. Yes, harmonic and bipolar can be used. I think there's no harm in that.
Dr. Sadiq, any concluding comments?
Sir, can I ask one question?
Yes, Dr. Shalu, please go ahead, please.
Sir, I want to ask one question. Usually we are doing cholecystectomy in the second trimester if the patient come with the symptomatic gallstones. So there is any difference in the pose position from the conventional port position?
Are you asking me, ma'am?
Yeah,
Yes,
Kamalji,
sir.
please take.
Yes, sir.
Yes, obviously, as we have to, the port placement, as I said, is triangulation method, the ideal one. But many times we have to modify the port position depending on the, as hepatomegaly might be there, or there's a large distended gallbladder is there, a big spleen might be there, or any other organomegaly is, as in gravid uterus may be there. you obviously have to modify your port placement, and their ideal triangulation will not be achieved. You see, even in appendectomy, we are not doing an ideal triangulation placement of ports. That phenomenon is called sectorization of ports. It's a very difficult view. I didn't have time, didn't want to touch that. It's a difficult view when you are sectoring the laparoscope or vis-a-vis when you are triangulating it. So that is, I would suggest, yes, but that's an advanced surgery. I would not advise novices to take it, because it's going to demand more skill and expertise in handling. Definitely modified port positions in pregnancy. There's no doubt on that.
Thank you, sir.
Kawaljit, one more question from Nabeen. What are your views about use of ligashore for cystic artery as compared to harmonic?
Obviously, it can be used, because why? But why use it? I mean, the question is, see, I'll tell you what. Advanced energy sources are very expensive, and in most hospitals, they will levy an additional cost to the patient. It's not, it's in the OT and you use it. So, but why use all these things when you have a cautery and you can use it, electrosurgical unit is there, and at the most, you can use it on a bipolar mode. Why go in for ligashore? Of course, it can be used. It can be used for vessels up to 7 millimeter cystic arteries, 1 or 1.5, and maximum, not even more than 2 millimeters. It can be used, but I would not suggest wasting resources like this.
I think we'll move on.
Sir, can I take this question?
Yes, Ajay.
Yeah, sure, Ajay.
Sir, just want to emphasize, very often the surgeons, what they do is they will put a clip onto the cystic artery, and then they will use a cautery also. I think that is a very wrong method to use, because the clip gets burned and there's a burn into the cystic artery beyond the clip, so it will start bleeding. So always take precaution that once you clip, don't use cautery.
Totally agree with you. Totally, and people are doing one more thing also. They use clips on the the CBD side of the cystic duct, and on the other side of the the gallbladder side, they'll cut with a cautery. Again, the same logic. No, that's not to be done. The clips will fall off. Delayed necrosis will happen. They'll fall off.
Okay. Thank you, Kamalji. Thank you, Dr. Shalu, for accepting our invitation.
Thank you, sir.
Now,
Thank you, sir.
move on to the next presentation, which is going to be Dr. Sadiq. And as I did mention yesterday, the brain behind this masterclass and the suggestion and all programming has been done by Dr. Sadiq, who is one of the leading faculty who strongly and makes a strong opinion about keeping cholecystectomy safe. And along with Dr. Ibrarullah, he has produced an excellent pictorial essay on cholecystectomy, which I think all students should ask their heads of the departments or heads of the institutions to buy a copy. There are beautiful pictures there describing each and every step and each and every possible complication. In fact, my colleague, Dr. Vinay Mahala, today asked me, how has Dr. Ibrarullah produced all these images? So they were all wondering. So next presentation is by Dr. Sadiq on difficult cholecystectomy, which is a very frequent problem, at least in North India. And to chair this, we have Dr. T.D. Yadav, who's a professor of surgical gastroenterology at PGI Chandigarh and the secretary of the IHPBA. TD, please.
Good evening to all, and thank you, sir, for giving this opportunity. And the topic being to be covered is by Dr. Sadiq, sir, and we know everybody knows him. So there is no need to introduce, and all the work which has been done in the field of cholecystectomy and benign biliary stricture. If you see the literature, you will find that how much contribution has been done. And as sir has suggested, that book has also been published. So the topic is very, very important. One is that two components, I think, sir, you said thick wall gallbladder. There is acute cholecystitis and a thick wall gallbladder. And both are very, very important. And I don't have to say anything. So I request Dr. Sadiq, sir, to start his presentation.
Thank you very much. My slides are on view, right? Yeah. Thank you, Dr. Kapoor, for allowing this topic to be in the second masterclass. We know that you have a great passion for teaching, and we all join that bandwagon in order to satisfy our need to interact with people. I think it's been a wonderful 1.5 sessions on cholecystectomy. Just to reiterate that we have been interested in doing safe laparoscopic cholecystectomy. We have had a few courses run, which was interrupted by COVID at that time. And this was the first course. And as you can see, Dr. Kapoor and Dr. Kishore, who was speaking yesterday, participated in that. And as has been mentioned, we took out, this was the COVID baby that Ibrar and I produced, because we had a lot of time on our hands and we put together what all we had for this atlas. Now, coming to the topic, it's difficult cholecystectomy and its approach to management. I've not specifically stuck to acute and thick wall, but an overview of a difficult cholecystectomy. The first important question is that what is a difficult cholecystectomy? And, there is no standard definition for that. And as a matter of fact, there was a Delphi consensus of Spanish experts trying to figure out how do you define a difficult cholecystectomy. And the usual suspects turned up: complicated acute cholecystitis, scleroatrophic gallbladder, bile duct injury, severe inflammation, Mirizi, and so on and so forth. So it's difficult to say that what is a difficult cholecystectomy. In my opinion, we could have the definition in these aspects. One is related to access during cholecystectomy. So if there are adhesions, previous surgery, that poses difficulty. If there is atrophy, hypertrophy, and malposition of the gallbladder, that produces difficulty in itself. So those are also part of difficult cholecystectomy. Then we have disease-related issues like acute cholecystitis and its complication, and again, contracted gallbladders, lost calots or hepatocystic triangle, Mirizi syndrome. Another component is a redo cholecystectomy. Now, more and more we are seeing this class of patients wherein there has been a cholecystectomy done and there is a residual gallbladder with symptoms, and we need to undertake surgery for this, which is, again, I would define it as a difficult cholecystectomy. And finally, in gallstones with cirrhosis, with or without portal hypertension, and certainly extrahepatic portal venous obstruction are important issues which need to be addressed and would sort of be nominated as a difficult cholecystectomy. And it's important to realize what is difficult cholecystectomy because the consequences are serious. You may have serious morbidity, which you don't expect in a cholecystectomy, bile leak, sepsis, bile duct injury. And if we have to convert, then wound-related problems in terms of infection and incisional hernia. So consequences are there. You need to be aware of what is a difficult cholecystectomy. So the best way to deal with it is to anticipate a difficult gallbladder. And I think yesterday, the first presentation with Dr. Ajay did addressed most of these things. And I'll just reiterate this, that the patient factors like elderly patients, obese patients, male patients generally would have a difficult gallbladder. Disease factors we discussed in detail: a thick-walled contracted gallbladder, acute cholecystitis of especially grade 2 and 3, and several days beyond the initial onset would make it more difficult. I would add xanthogranulomatous cholecystitis in this, and of course the complications of acute cholecystitis like empyema or perforation. And then we have Mirizi, cirrhosis, and post-ERC. So all these, if you have any or a combination of these, you should anticipate that this gallbladder may be difficult to do. So what do? In such a scenario, you need to evaluate these patients well. That means we may say, for example, a patient having acute cholecystitis going on for 5 to 7 days, I would do a plain CT to understand the extent of swelling, any complications, and adhesion to adjacent viscera. If there is altered liver function test, as again was discussed yesterday, an MRCP. So additional evaluation would be required for these patients. I think important thing is counseling the patient, because generally cholecystectomy is a straightforward procedure which we all consider. And in this scenario, You may have a conversion to open, and this needs to be addressed and discussed with the patient. You need to prepare, so check your own expertise and available expert help if required. Kawalji talked about energy sources, and in this scenario, you may need advanced energy sources. And a word about cholangiography I will discuss during the presentation. And the goal of this treatment is to do the cholecystectomy safely, minimize short and long-term morbidity. And the way to do it, as I said, is anticipate, intraoperative assessment, and the boss of difficult cholecystectomy is the bailout strategy. So always remember that boss is something which we need to keep in mind, and we'll discuss about that. Let me just cover this. I won't delve into this a lot. Access related. So whenever you have prior surgery or resurgery of any form, you need to plan your entry. So VisiPort from Palmer's Point or any other virgin area or an open access. You need to strategically place these ports so that if there is adhesiolysis which is required, you may need extra ports away from the area of interest and then reach that area. And as I said, if there is situs inversus or malposition gallbladder and such anomalies, then the port position would be altered. Now, if there is a difficult gallbladder, as we have anticipated, I personally would prefer these things to be done. And I've been using a 3D optical system for the last 5 to 6 years, and it has made my life at this stage of my career very easy to deal with difficult gallbladders. One of the things we usually need to do is decompress the gallbladder because it is usually tense, it is thick-walled, and it is difficult to grasp and retract. As we discussed yesterday, landmarks are important in order to proceed for the dissection. And I think in this scenario, the R4U line, which we discussed yesterday, is critical to determine where you should be during the dissection. If this landmark is not there, then a cystic lymph node, in my opinion, is a very good landmark to be lateral to that and start working from there on to identify various structures. And in my experience in the last 3 years, we feel that ICG cholangiography certainly has a role, and I'll show you in another talk and in this talk also. Now, if you have to do the dissection in this situation, as in any scenario, stick close to the gallbladder, but especially in acute scenarios and acute on chronic cholecystitis, a blunt dissection with the suction tip is your best mate. And you can do practically 70 to 80% of cholecystectomy with a blunt dissection in this scenario, which I would not recommend in any other scenario. Also, I'm sure all of you have noticed that there is that distinct plane which if you enter during this difficult cholecystectomies, which I call this the holy plane, you would be in the best place preventing injury to adjacent organs in the hepatoduodenal ligament, like artery and bile duct, and safely do a cholecystectomy. So while you are doing this dissection, you constantly assess and reassess. If it is a thick-walled, seriously thickened gallbladder with obliterated calyx or hepatocystic triangle or a lost hepatocystic triangle, the landmarks are unclear and lost. That is the time that you need to look at other options. And here I want to point out one specific caution, that to define anatomy in difficult situation is invitation for trouble. And herein you are encountered with this Anakin's paradox, that when one action you are trying to do to prevent something could lead to what you are trying to as a catalyst for that occurrence. And herein specifically, in difficult situations, your effort, persistent efforts to define a CVS in order to prevent bile duct injury may actually lead to a bile duct injury. So just a caution, and I'll share with you how to deal with that. So when you have that kind of a scenario, you need to look at bailout strategies, which I call it the boss of difficult cholecystectomy. So you need to take a middle approach, that is, you divide the gallbladder after dissecting in the liver bed, and you have two components. The fundus part you use to retract, and the distal proximal GB you dissect out, and by looking intraluminally, you know that how thick is the wall, and accordingly you can dissect and narrow down to the cystic duct area. Also, there are two other components: fundus first dissection, which Strasbourg has classified as an error trap. And I think it is a very good tool to have. And the technique should not be criticized. It is the way you do a technique which should be learned and implemented. And the final thing is a subtotal cholecystectomy. So if anatomy is unclear in a difficult scenario, you have options. You abandon the procedure, and we get a lot of patients these days where it has been abandoned. And I appreciate the surgeon who has realized the limitations and has abandoned rather than do any harm to this patient. And you can always complete the cholecystectomy subsequently. You have an option of a tube cholecystostomy. It addresses the immediate issue at that time, especially in situations where everything is stuck badly and it is a bad time of inflammation with risk of injury to adjacent structures. So if you do this, you have an option of coming back. And of course, conversion is an option always, provided it is elective and not forced. It is a good judgment sign and a sign of maturity. And it is an important wheel in the clog of safe cholecystectomy. But based on the expertise, you can minimize the requirement of conversion in this, even in difficult gallbladders. So apart from this, you start looking at what other options you can implement. So you decompress the gallbladder, as we talked. You identify the landmarks. And as I said, that artery first you can take, provided you take it lateral to the lymph node and also on the gallbladder. And finally, eventually fundus first or subtotal cholecystectomy based on experience and setup. So when would I do a fundus first dissection? When it is difficult dissection in the hepatocystic triangle, difficult to retract gallbladder or a sort of cirrhotic liver, and I'm planning to do a subtotal cholecystectomy. Also in redo cholecystectomy, I would do a fundus first. So the technical issues are dissect always close to the gallbladder. Do not breach the cystic plate. I would err to open the gallbladder rather than go into the cystic plate. And what I do is I would mark the limit of my fundus first dissection to avoid getting into the hepatoduodenal ligament, and I would put a sort of incision or mark on the GB or put a gauze piece there, so that that is my limit of dissection so as to not fall into the error which Strasbourg talked about. And there are a lot of these publications now, and as a matter of fact, a systematic review and meta-analysis of fundus first, which says it decreases the conversion, less time of surgery, and shorter duration of hospital stay and bile duct injuries. So it is an option to be exercised. The second one, the classic paper by Strasbourg of fenestrating and reconstituting type of subtotal cholecystectomy, wherein you close the cystic duct from inside, leaving the wall open, or you reconstitute the sort of stump of the gallbladder, ensuring all the stones and all are removed. So as far as subtotal cholecystectomy is concerned, you need to fulfill certain caveats. Divide the GB, leaving adequate but not too much gallbladder, so as to you can do a safe closure. I would transect it with some energy source, because if you have not taken the artery separately, there is a risk for bleeding. Important thing is to extract and clear all stones from the stump. Option to cauterize the GB mucosa and close the stump carefully. Regarding intraoperative cholangiogram, conventional cholangiogram is difficult to do because cystic duct is not identified and you may not be able to do a cholangiogram through the gallbladder. But ICG cholangiography with certain limitations may be a good tool. And again, there is some literature to suggest that in difficult cases, it improves, reduces blood loss, length of stay, and fewer adverse reactions.
Sadiq, another 3 minutes.
So let me just play this 3-minute video, which will cover all these aspects, what we were talking about on cholecystectomy. So this was day 7 of acute cholecystitis. Adhesions are there. Usually, when you reach that area, you can see that you do a blunt dissection with suction, and most of it can be cleared off. Careful harmonic to release the adhesions in the gallbladder. Now you see that it is blending into the gallbladder. It needs decompression, which now we have done. Now, despite doing this, it is very difficult to differentiate the gallbladder from the liver, and the hepatoduodenal ligament and hepatocystic triangle is frozen. You try to look at the landmarks, and I have sort of made a assessment and put a marker wherein I would stop doing my dissection. Now, this is where you enter that very significant plane, which is safe in this. Use an ICG cholangiography, and with great difficulty, you can see the common bile duct. So at least you know where your limit of dissection is. Once you get into this holy plane, now you see that you can dissect in that area, use the edema and of the acute cholecystitis, and sort of bluntly dissect the gallbladder. And here you can see how tissues fall away and gallbladder can be dissected up. Again, in the liver bed, you can dissect off the gallbladder. And the good part is the thick tissues surrounding it protects the organs in the hepatoduodenal ligament and the bile duct for injury. And as a matter of fact, a lot of this blunt dissection can be continued, and you can identify all these major areas. The fundus part was difficult to do, so I had to resort to a fundus first approach in this area. Again, remaining close to the gallbladder, the fundus first area dissection was adopted. Again, as I said, something to protect and limit where you dissect. So gauze fees is used, and then you continue the fundus first till you reach or narrow the gallbladder towards the neck. And this is, I mean, with careful meticulous dissection being close to the gallbladder, even in the most difficult scenarios, you can do this. Now you have separated the gallbladder, and what is attached now, this is the cystic artery, which you would clip, and then eventually the cystic duct would be clipped. So artery is clipped, and then hemolog on the cystic duct, and cholecystectomy is completed. And as we were discussing yesterday, that we need to look at the area. Now you see it was an intrahepatic gallbladder, a superficial vein is seen, it could have been damaged, and you can achieve a complete cholecystectomy with great degree of certainty and safety. So I'm just going to skip this, redo course. So difficult GB is a challenging problem. It requires judgment, critical decision, good skills and expertise, and knowledge of all the options. But most importantly, anticipate, prepare, and execute a plan. And the choice and timing of which boss to answer to is the key in preventing bile duct injury during a difficult cholecystectomy. Thank you very much. And if it's okay, and while we are discussing, if these videos play, I can let it be playing. Thank you very much.
Thank you, sir, for very nice. This video was so wonderful that certain areas I was not able to even understand that how you are going to take this gallbladder out. It was looking like a liver only. So nice demonstration of blunt dissection, which is very, very important, especially in acute setting. So I just want to clarify one thing for the audience that you did touch about portal hypertension, so which has a chronic liver disease as well as EHPVO. So would there be any difference from your side for the message for the people who are listening about the approach if the patient is a EHPVO and vis-a-vis chronic liver disease?
I had that slide, and
Okay.
I certainly would differentiate between cirrhosis with or without portal hypertension and also EHPVO. So cirrhosis, in most situations, you would be able to do a cholecystectomy with its accepted difficulties, which is difficult to retract liver, risk of bleeding, and I would more often than not do a modified kind of subtotal cholecystectomy, wherein I may leave the wall of the gallbladder on the liver bed and close the cystic duct from inside, or even do a reconstituting type of cholecystectomy. And as I said, that careful use of energy sources and anatomical considerations, you would be able to do a complete cholecystectomy in most situations. In cirrhotics, EHPVO is an entirely different ballgame. And I think we need to be very, very vigilant if we are taking this. And I would never want it to be a surprise on the operating table. So that means you should be aware, your ultrasonologist should look at portal vein and tell us if there is a EHPVO with collaterals, because that's a recipe for real disaster if you try to do a cholecystectomy in that situation without proper preparation. So if there is EHPVO, and if I have to do a cholecystectomy, then I would, even in this stage, prefer doing an open cholecystectomy so that I can take care of all the collaterals with good control. And of course, it would be a modified kind of cholecystectomy depending on the situation which I encounter at that time.
Okay, thank you, sir. Yes, sir.
Yeah, please take the comments and questions from the chat also.
So yes, one of the question is respected sir, is it safe to employ endoloop after subtotal cholecystectomy rather than reconstituting or fenestrating suturing subtotal cholecystectomy in acute and difficult cases? How much is the risk of post-op bile leak or other morbidity following bailout procedures? Thank you. This is a question from Dr. Bird Prakash.
Yeah, so yes, endoloop can be used if it is used properly with adequate stump. Also, I've used sparingly endoloop. I always, either after putting an endoloop, put a hemolock clip, or I would still put a suture in that for double safety. As far as bailout procedures are concerned, again, there are meta-analysis and systematic review which have shown that there may be a slight increased incidence of bile leak. To be very honest, there are incidences of bile leak in this, but with experience and over the last couple of years, we have found that even after doing a subtotal cholecystectomy, our risk of bile leak has come down dramatically. And we, though, put a drain in these situations, but most of the time we don't have bile leak. So yes, bile leak is a morbidity which you would expect if you do a subtotal cholecystectomy, but that is a small price to pay in contrast to a major injury either to an adjacent viscera like a duodenum or the bile duct, or some major injury to the artery. But the caveat must be fulfilled.
Yes, sir. Yes, sir. Another question is from Dr. Shalu. Yes, sir. Dr.
Yeah,
Kapoor.
there are two comments. Maybe you can take them above the Dr. Monica and Dr. Shalu Gupta.
So Dr. Shalu, this question I was going to take. Dr. Shalu, when we are doing fundus first, many times there is a bleeding from the liver, which obscure the vision. So is there any trick?
Yeah. Yes, that can happen. But as I said, that I try to err to be in that subserosal plane or into the gallbladder. But if there is a bleeding, we generally keep a gauze there. And what I use is hold the gauze with a forceps and then use it for retraction and compression. So it does two jobs. While you're doing a fundus first down, the liver can be retracted still, like you see in this video at this point of time. And then it also by compression controls most of the bleeding.
So there is one more comment, sir. If you want to give something, comment is
just
that
one more.
Dr. Monica agreed that counseling for difficult gallbladder has to be carefully done. Chances of open operation and finding fistula need to be explained. Fistula means, are you thinking about cholecystoduodenal or cholecystocolic fistula? It seems.
Yes.
So, yes.
And
1 in
there
10
is a-
thick wall.
Yeah, there is a question from Ajay also, and there is one more, Uttam Lodari. Maybe after that we will. move on
Ajay,
to
question is same, sir. What Dr. Sir has taken, that if there is a bleeding, how to handle. I think that is that was part of that question.
No, Ajay's question that in fundus first, how to retract the liver.
Same
and
thing,
how to
same
control
thing,
the remnant.
same
Let me
thing was
take
the
that.
same thing was yes.
Yeah, let me
Yeah.
just take that. So Ajay, as I said, that I generally use a gauze piece and the retracting port, which we use in the right uh, uh, lateral port, which we use, that will be used to retract the liver while we are doing the fundus first. And as far as closure, earlier I used to do interrupted. Now I do continuous, and any of the sutures are okay. Sometimes I use V-lock, sometimes PDS. I don't have any specific preference, but sometimes when it is difficult to control or hold the suture well, then V-lock is good in this scenario.
Take
So
the
another
last
question.
also, sir.
Can I share?
Another-
Can I share
another-
experience?
Dr. KJ, just let me read the question, then please go ahead. So can you please discuss about the liver pucker sign as a predictor of difficult cholecystectomy?
Yes, I think that is definitely there. It just indicates again the same point that it is a contracted gallbladder with probably intrahepatic component, and certainly it indicates straight away that it is going to be a difficult cholecystectomy.
Yeah, KJ
So,
has commented, then we move on.
Sir, Dr. Sadiq, I have twice or maybe thrice in the last around 20 years, I've used endo-GIA for subtotal cholecystectomy. It's a wonderful procedure. Obviously, cost factor is there, but if you split the cost and charge only for the cartridge, it adds up only maybe around 7,000 to 8,000 rupees to the patient. But it really gives a lot of ease. Sir, have you ever tried that endo-GIA green cartridge?
I'm glad that you brought this up. When I was not very confident of suturing in the initial phase, I used this maybe 2 or 3 times, and that's about a decade back.
Yeah, same here, sir.
The problem is that if you use a cartridge, the application of that in the closed gallbladder runs the risk of leaving stones, which you're not sure. And if you amputate and then use that, then making sure both the lips come and all requires a lot of manipulation. So I would rather suture than put a stapler.
So last one.
I'm sorry, just 1 minute, TD. Only other
yes,
situation which I've heard Ibrar use, and that is in EHPVO when he did a subtotal cholecystectomy, wherein he used a cartridge for that. And I think that makes a lot of sense. But again, we are not sure about the stone status in the remnant and how big you are leaving behind.
And for a cholecystoenteric fistula. Okay. TD,
so,
any last?
my last comment would be about all these things are for the open also. I think it seems that we are only emphasizing laparoscopic bile duct injury management. In our experience in PGI, even today, our data of open and laparoscopic bile duct injury are same incidence I'm talking about. So all this, whatever has been discussed, is the same for the open cholecystectomy, and all the techniques are, I think, almost same. So maybe the people who are listening, they should know that even open can do the same type of bile duct injury if our training and principles are not the same. Thank you.
Okay.
Thank you, sir.
Thank you, Sadek. Thank you, TD. We move on to the next presentation, which is by Dr. Anu Bihari. She is a professor of surgical gastroenterology and my former colleague for more than 3 decades at SGPGIMS. And the presentation will be chaired by Dr. Paleswan Lucky Joshi from Kathmandu, Nepal. Anu, are you there? Will you be able to share your presentation or do you want me to share it? Anu, आप muted हो. Please unmute yourself.
Thank you, sir. Good evening, everyone. So after the excellent presentation by Professor Sadiq Sikora, it is my honor to invite Professor Anu Bihari. She is the consultant and professor of surgical gastroenterology at SGPGI Lucknow. And I would like to invite her for her talk on troubleshooting in cholecystectomy, bile leak and bleeding. Dr. Anu.
Anu, are you able to share your screen or you want me to share your presentation?
Only the host can do. So will you
Okay.
please share? Are you able to hear?
I'll do it. I'll do it. Is it seen?
Yes, sir. Am I audible?
Yes, yes, please. Yeah, please start.
Very good evening. And thank you very much, Dr. Kapoor, Dr. Sikora, for giving me this opportunity to participate in this very needed masterclass on safe cholecystectomy, an issue that is very close to my heart also. And if we see today, cholecystectomy should be done with almost no mortality, very little morbidity. And the expectation is that this will be an operation admitted on, say, the evening of the operation, will be operated, will be discharged the next day. But the scenario can, when I go back to the previous slide.
Sorry, I'm sorry.
Yes. But as soon as bile duct injury or vascular injury enter the equation, suddenly the situation doesn't remain so simple at all. The mortality, the cost, hospital stay, number of interventions, everything increases exponentially, and suddenly mortality is very much a possibility. And this situation is very raw for me. Last night, the department lost a 34-year-old mother of 2 following a laparoscopic cholecystectomy injury, was referred very late with sepsis and multi-organ failure. So may I please go back to the previous slide? I'm sorry about this. So, sir, may I please go back to the second slide?
This one or the next? This one?
Hello.
Yeah. This one or next?
Yes, sir, this one. So I know that the topic that has been given to me is like troubleshooting. So meaning what to do when trouble strikes. But considering the potentially devastating consequences of major vascular biliary or combined biliovascular injuries, I think the surgeon's intent and efforts should always be geared towards, I think all the speakers who have spoken yesterday and today have emphasized this culture of safe cholecystectomy, and I feel that understanding and rigorously following the basic tenets of safe cholecystectomy are fundamental and essential to minimize the occurrence of major vascular or bile injury. So basically, what we need to know is the relevant anatomy of the region, including all the variations in biliovascular anatomy and their surgical significance. We also need to understand the surgical significance of alterations in anatomy, which may be brought about by altered pathology, as in acute cholecystitis, as you just saw in the presentation by Dr. Sikora, long-standing gallstone disease, chronic cholecystitis, Miruti syndrome, presence of associated diseases like cirrhosis, portal hypertension, and EHPV, as previous speakers have mentioned. Previous surgical or non-surgical procedures, say upper cutaneous cholecystectomy, upper abdominal surgery, previous intra-abdominal conditions like, say, pancreatitis, and the management options in the face of altered anatomy, physiology, and pathology. So, as Dr. Sikora's presentation on difficult cholecystectomy, so may I move the slide? Next slide. Difficult cholecystectomy will translate into an increased risk of intraoperative bleeding and bile injury. So we should prepare well. And how do we do that? By appropriate patient selection and preoperative optimization, having even a better assistance than you would usually, including help from a more experienced colleague, intraoperative biliary imaging, well-maintained instruments and energy sources, and topical hemostatic agents. But most importantly, I think every surgeon needs to match one's experience to the difficulty of surgery. And this is a graded progression. I don't think a newly passed out MS general surgery resident can do the kind of cholecystectomy which Dr. Sikora just did. And that is not a problem. The experience is going to increase gradually. The surgeon should know which patient to choose. Always keep safe bailout techniques in mind, including retracting the decision to continue with cholecystectomy or give up totally. Next slide, please. Intraoperative bleeding, and right at the beginning, I'll say that today I'm not dealing with trocar-induced or access-induced injuries to the major vessels, and I'm restricting myself to bleeding during the anterior cholecystectomy, which may vary. It's a huge spectrum from minor, easily managed to catastrophic bleeding, leading to hemodynamic instability during surgery and liver ischemia requiring early or late hepatectomy later part of the post-operative procedure, post-operative period. Next slide, please. May I have the next slide? Sources of bleeding during cholecystectomy. Now, they can vary from, like, even before you get to the gallbladder, there may be pericholecystic adhesions, momentum being very common. So, mental vessels may be there. The trocar sites may be the source of bleeding. The liver, especially when it's cirrhotic, fatty, even adhesions which are so simple, and in a normal liver, they just lead to this small abrasion of the liver surface, can lead to bleeding. And usually that is because of inappropriate traction or incorrect plane, and can be taken care of with sharp dissection in the correct plane. The liver, especially when it is cirrhotic and fatty, may also get injured from ports and instruments and forceful GP retraction. Next, please. The most common source of intraoperative bleeding during cholecystectomy is the GP bed. Now, from the bed, the bleeding may be in the form of diffuse ooze, as may be seen in acute inflammation and when cholecystectomy is done for acute cholecystectomy, or because of the collateralization, as may be there in cirrhosis and portal hypertension. Bleeding from the GP bed may also be because of injury to terminal tributaries of middle hepatic vein. In about 10% of people, these can be very close and may be very large, as was shown by Dr. Brar and also Dr. Sadik. Also, it is very important to remember that injury to the right portal pedicle is possible if in long-standing chronic inflammation, there is thickening and foreshortening of the cystic plate. So as we come close, and especially if it is a small contracted gallbladder, we may very quickly reach the right portal pedicle. And chances of what Strasberg has called devastating like ambulovascular injuries can happen. More common sources of bleeding can be, next slide please, the cystic artery. It may be the normal cystic artery during dissection or one of its branches, or more likely an aberrant cystic artery, which is of its location and number may be variable, and very importantly, a very short cystic artery. The right hepatic artery, which is the most commonly injured major vascular structure in cholecystectomy, is more likely to get injured if it is anteriorly placed to the common hepatic duct, in contrast to its normal usual posterior position, or when it has what is called as a caterpillar hump. The thing is that whenever there is a caterpillar hump, usually it is associated with a very short cystic artery. Luckily, and the portal vein branches is much less common, but can be devastating, as can be combined arterial and venous injuries. And in fact, I think portal vein injuries, many of them are actually underreported because many of these patients who have torrential hemorrhage may not even reach the center from which reports of injuries come. Now, what happens when you encounter bleeding during cholecystectomy? What you should absolutely not do is panic and start. If it is a laparoscopic cholecystectomy, don't start cauterizing or clipping, suturing. It is going to be ineffective first, and most importantly, it can lead to other injury. In fact, it can lead to injury to the bile duct, or may exacerbate the already present vascular injury. What you should do is pause. Just put if it is laparoscopic, you can still put a pack and gauze open. Again, you can put pack and gauze. Press and wait. Be patient. While you are pressing, it will give you time. You can call for help. You can reassess your situation. And if you're doing it laparoscopically, you can think whether you need an extra port for suction, for resistance, and also think whether you require conversion. Next slide, please. Now, when you are pausing, like again, one of the tenets of safe cholecystectomy to pause. Now, this is the time when you have bleeding. What you need to assess is, what is the site of the bleeding? What is the nature, like a arterial spurter or like venous ooze? Extent, is it just a small trickle or it's large amounts are coming? And this will allow you to assess whether you need help from a more experienced colleague, whether you need extra ports, whether you need extra instruments or energy sources. And while you are assessing, just keep the pressure there and don't remove the gauze every 2 minutes to see whether the bleeding has stopped. Also, very importantly, inform the anesthetist that there is bleeding. Normally, during cholecystectomy, blood will not be arranged unless you have seen that preoperatively you have detected that the patient has portal epilepsy and you want to be better prepared and you already have arranged blood. But inform the anesthetist so that resuscitation and arrangement of blood products can be made. Put another port for suction if you're not able to do with the number of ports that you have. Keep the field clear as much as possible so that the bleeding will come down to a level that you can assess whether you will be able to use cautery, clip, suture, or a topical hemostat as may be required. Also assess the need for conversion to open. Now coming to the gallbladder bed, which is the most common site of bleeding during cholecystectomy, as has been stressed by so many others, and I would like to reiterate, a difficult gallbladder bed should not be a surprise. And in difficult cases, preemptively we can choose to leave the posterior wall attached to the liver and ablate the mucosa. Remember that the right portal pedicle can be really close and in danger of injury in patients with small contracted gallbladders who are likely to have foreshortened and thick cystic plates opt for a bailout technique like subpleural cholecystectomy or even a cholecystostomy or even just putting a drain and coming out. If the bleeding from the gallbladder bed is a diffuse ooze, as is likely to happen, say, for example, you have operated for a patient with acute cholecystitis, initially put pressure with gauze, use electrocautery, like a spray mode we can use, depending upon how much is the bleeding. Local hemostatic agents are good for this kind of bleed, and oxidized regenerated cellulose, which is Surgicel. Many studies have shown that it's quite helpful in many such situations. You can put it there, put your gauze piece, wait in, and diffusers should be taken care of. People have used gel foam, fibrin glue, even omental flaps and falciform flaps to assist. Don't use electrocautery indiscriminately because there is the likelihood of injury to subvesical ducts and also terminal tributaries of middle hepatic veins. Omental arteries, usually after you have had, after with suction, pressure, you have had a clear field, then you can use cautery, one of the energy sources, or suture or ligate if you're doing an open procedure. The cystic artery and branches also can be reclipped. You can use one of the energy sources, or you can use a ligature or suture depending upon your condition. The right hepatic artery is most often, actually, at times of bleeding, gets clipped and goes unnoticed. If it is noticed that the right hepatic artery has been injured and you have seen it intraoperatively, assess if it is possible for you to manage it laparoscopically, otherwise convert and suture or repair. If expertise for repair is unavailable, it is better to secure it safely and tie it off, control the bleeding, and monitor closely for evidence of liver ischemia. It may happen in not more than 10% of patients, and there are several other factors which may be, if there is no associated bile duct injury, if there is no associated portal vein injury, the patient may escape major liver ischemia. When should you start getting worried? If there is ongoing substantial bleeding with all that we have done, it is likely that there is, especially from the gallbladder bed, that there has been a venous injury or a combined venous and arterial injury. Start reassessing your options depending upon your experience and the infrastructure that is available to you. If you feel that by converting, you can suture control, you have the ability, you can do a Pringle maneuver, take sutures over the vein, you can do it, but continue careful monitoring for bleeding and liver ischemia. If you can't, convert back and refer. Continue resuscitation, stabilize as much as possible, document in detail before referral. If possible, talk to the people in the center that you're referring, explain, get their advice as to how you should manage while you are shifting the patient, and then shift the patient.
Anu, another 2-3 minutes.
At what stage of dissection? You may discover bile leak after having achieved a clear CVS and removing the GB bile leak from the bed. You may notice that a cystic duct a clip has slipped, say because of inappropriate size, too thick, too wide, while dissecting the cystic duct artery. Sometimes, after having clipped and divided what you thought to be the cystic duct and then dividing some more tissue in the GB bed to separate it completely, what is the classical injury? The bile is from the divided CHD. Very scaringly, very frighteningly, sometimes after prolonged attempts to control bleeding with the electrocautery, bile is seen leaking in the field. I would say, unless it is clearly from the gallbladder, like the greenish yellow bile with some stones, take it as ductal injury. Now, once there is the suspicion of injury, again, we need to pause because we need to assess three things. The injury, meaning identification of the duct, the extent, the level, associated vascular injury. We also need to assess the expertise that is there of intraoperative cholangiogram, laparoscopic or open management of the bile duct injury, and the infrastructure, whether there is a support for the laparoscopic or open management, endoscopic interventions or radiological interventions. Now, should we convert just because we think that we have injured? Mere conversion may not improve exposure or clarify anatomy, because even a difficult cholecystectomy will remain difficult at open also. And experience with open cholecystectomy, this may be even more so. And the same care has to be taken after conversion to ensure that the injury is not further compounded. If proper assessment can be done laparoscopically, conversion is not a must. If the surgeon's assessment is that because of lack of experience or infrastructure, the surgeon is going to refer, then just put a large subhepatic drain laparoscopically and refer. Or if the surgeon clearly recognizes that the experience and expertise is available and can be managed laparoscopically, then also there is no need to convert. Now, if the bile leak is from the bed, I think this was discussed yesterday. If it is less than 3 millimeter, we can clip or suture. If it is more than 3 millimeter, it is likely that it may be draining a large sector or segment. So all subvesical ducts are not the same. And that is why the injunction to do a bilioventric anastomosis if it is a larger duct. Assisting ducts slip clip can be managed by reclipping, endoloop, or suture. Always put a subhepatic drain. If there has been a complete transaction, especially with tissue loss and high injuries, a RUVIJ is advised, but with the caveat that no associated vascular injury is there, in which case even experienced surgeons may choose a delayed repair. If there is partial or complete loss, there is a space for end-to-end anastomosis with fine monofilament sutures. People always say T-tube, but I always wonder when a common, like a normal size CBD is injured and like you are stitching it end-to-end, you want to bring out T-tube from another hole in the CBD. I mean, that is, in my mind, compounding the injury. We can do it over a stent also, or simple suture with a subhepatic drain. And we can elect for post-op endoscopic stenting, depending upon what is the extent. If expertise and infrastructure is not available, put a large subhepatic drain, document the intraoperative findings, whatever you found, and the procedure, inform and counsel the patient and family, and refer to a center where expertise and infrastructure are available. So if I have to say what messages, obsessively follow the basic tenets of safe cholecystectomy. Do not let the apparent simplicity of the procedure lull you into a false sense of security. Learn to anticipate and prepare well for difficult cholecystectomy. Tailor and match the patient selection to experience. Do ask for help in a difficult situation. Honestly assess experience to deal with major bleeding bile leak and act accordingly. Choosing referral is not a failure. It may be the wisest and safest decision that you have ever taken. Do refer after resuscitation, stabilization, drain placement, and packing. As Dr. Kapoor always used to say, to injure is human, to refer is divine. Thank you.
Thank you.
Thank you, Dr. Anu,
Yeah,
for
please.
thank you, Dr. Anu, for your nice elaboration on troubleshooting in cholecystectomy. And you rightly said that the complications like bleeding and bile leak occurs because of 3Ds, that is dangerous disease, dangerous anatomy, and dangerous surgery. And you've very nicely elaborated the various techniques to manage bile leak and bleeding. And are there any questions from the other faculties? I don't see any questions in the chat.
Take the questions and comments from the chat box. If you open the chat, you want me to read it?
So I don't see any particular questions for Dr. Anu. So there's one question by Heathen Win, where the question is, can you please share, if any, experience the injury to accessory right hepatic artery during lap chole?
Actually, I have not experienced myself personally. I don't know if Dr. Sikora or Dr. Kapoor would like to.
Yeah, but the management would be same as of a normally placed right hepatic artery. So I don't think it would be any different. Only thing is that if it is really an accessory, not a replaced, then you have a low threshold to just clip it to control the bleeding, because you know that the normal artery is also there. In fact, I always tell a general surgical audience that if you have a right hepatic artery injury and you are finding it difficult to control, in a normal liver, which is not cirrhotic, ligating or clipping the right hepatic artery most probably would not do much harm, except some elevation of enzymes in the post-operative period. So if it comes to that, it is better to save the life of the patient rather than try to continue to save the right hepatic artery.
Can
Sadiq?
And so preoperatively, like
Sorry, go ahead, Anupam.
Can I make one comment? KJ, is it
Yes,
okay?
sir.
Can I make a comment?
Yeah, sir, I'll take it after you. Yeah, sure, go ahead, sir.
So, I mean, Anu, you did a great job in telling how to control bleeding and what to do. I want to reiterate that all bleeding stops with pressure, especially those during a cholecystectomy. And pressure is the treatment, not cautery, not clip. And that has to be emphasized, that at least you would get enough time to assess, reassess, call for help, prepare, and then you would see what is the cause of bleeding. So I think pressure part is very, very important. So that you have emphasized, and I think that has to be the most important message which goes from troubleshooting, which we can put.
So I'm sorry, I did a mistake. Kamaljit, yes.
Yeah, good evening, Dr. Anu. Great to listen to your lecture. All practical points valid and well taken. I have a substantial experience of roaming a repair of CBD injuries in the field. In fact, to the extent that I have a fine set in my car, always autoclaved with the number 10 T-tube. But once it so happened, and a couple of times it's happened, that the T-tube number 10 is usually not available easily in the market. Only a GI surgeon who's taking interest in CBD, salvage would ask for it. It's difficult to procure it. So I've multiple times what I've done is, and in centers where there's not enough lighting or not enough infrastructure to do a RYHJ, in those centers, I mean, as a bailout procedure, you may call it, or as whatever, end-to-end CBD repair is definitely an option. But I always use a T-tube once, so many times when the T-tube is not available. Just as a temporary measure, what I do is take a 6-7 number infant feeding tube, cut it, and use it as a stent, because obviously stent is also not available. The tube will pass off in a couple of days, 3-4, but it will do its job of allowing a good anastomosis or end-to-end anastomosis. It works well in cases in which I've tried.
My suggestion, KJ, since you carry fine instruments and all, carry stents also with you.
Yeah, I know, sir.
Avoid T-tube.
Yes. Totally taken.
Can I add to one more point? If you are
Just one more minute,
I think
because we have 2 more presentations.
No, sir, then it's okay. I just wanted to add that you should have a magnification and use at least PDS at 6.0, not less than that, because our duct is very small. So if you are doing end-to-end, we have to be very careful about selection of the suture material as well as magnification.
Totally agree.
So I think I did a miscalculation. Actually, 3 presentations were supposed to be 20 minutes each, but I gave 30 minutes to all the presentations. So Sadiq, what we'll do, we'll skip the last one, the medico-legal aspects. I'll post
No. Mine is not very long, so you please also participate. I'll finish in about 8 minutes or so.
Okay, so next is again by Dr. Sadiq, a presentation on intra-op evaluation. And to chair that is Dr. Monica Gupta. She is one of the senior GI surgeons in the city of Jaipur. Monica, you are there?
Yes, sir, I am there.
Yeah,
I am
please start.
starting my video.
Yes, please start the session.
Dr. Sadiq Sikora, sir, needs no introduction. He has been honorary secretary of Indian chapter of IHPBA. He is president IASG at present. He is heading as a director, Department of Surgical Gastroenterology, Sakra World Hospital, Bangalore. Sir's presentation is on intraoperative evaluation of extrahepatic biliary anatomy. And as we all know that extrahepatic biliary anatomy is most important aspect of safe cholecystectomy. So over to you, sir.
Thank you. I think what I'm primarily going to do is introduce the ICG cholangiography and its use, since we've been using it for 3-4 years. And it's not going to be an overview and what all methods to use to identify extrahepatic biliary anatomy during cholecystectomy. So these are the methods which are available. We observe by white light, intraop cholangiogram, ultrasound, and near infrared cholangiogram. So as far as intraop cholangiogram is concerned, there are several issues with that. You need good operation theater facility, good fluoroscopy, equipment, expertise, cost. Sometimes it is difficult to perform because cystic duct is blocked. But more importantly, it has been documented that almost 2/3 of time, there is a poor interpretation of the cholangiograms, and that is a serious limitation of intraoperative cholangiogram. And often the injury occurs while you are attempting to do an intraoperative cholangiogram, especially in an unclear anatomy. So these are the limitations. So what is next? And I think this new kid on the block, not so new anymore, this fluorescence, because of the contrast agent which absorbs light and emits at a longer wavelength, detected by a sensor and projected at a monitor in real time, this technology has now has come to the fore. And with the use of this fluorescence cholangiography, we may be able to visualize the extrahepatic biliary system. So there are two ways of doing it. Either you inject this intravenously or by direct injection into the gallbladder. The timing and dosage of administration is a matter of debate. Usually, to get a good resolution, you need to inject IV about 3 to 7 hours prior to the cholecystectomy, and you use a normal dose of 5 milligram of ICG. Now, this is what you would see if these are straightforward cases, which you would see. You are seeing in white light, the biliary anatomy, but this is how it fluoresces, and it just stands out. And you can see the liver fluorescence, the bile duct, common hepatic duct, and cystic duct in this parallel cystic duct, which you can see. So this delineates the extrahepatic biliary system much more clearly for our visualization. And the structures which you can see very well are the bile duct, cystic duct, pre and post dissection, and even at the end of this. And it gives you a certain degree of assurance and confidence that you have not injured the extrahepatic biliary apparatus. Generally, cystic duct is the most commonly identified structure, followed by the common bile duct, then common hepatic duct, and the CD-CHD junction. Now, the benefits of near-infrared cholangiography are immense. It's technically easy. If you have the system, then it is quicker and cheaper, and there's hardly any learning curve. There is no radiation. But the most important thing is it is a dynamic real-time assessment which you can get as far as the extrahepatic biliary system is concerned, which is in contrast to an intraoperative cholangiogram where you see a fluoroscopic image, you want to now overlap it on the laparoscopic image, and it can't be done again and again. And of course, there is no possibility of bile duct injury. There are certain limitations, especially in obesity and acute inflammation, because of the limit of penetration of these wavelengths. So if they are thick tissue, then it is difficult to visualize. And also we must remember that various systems have various requirements in terms of dosage and timing so as to best visualize the extrahepatic system. So we did a study in acute cholecystitis, and what we saw was very interesting because we thought that this is a scenario where if you see these, it'll be nice. So all three structures, which is cystic duct, common bile duct, and CHD, were visualized in about 1/5 of patients, and after dissection in 42%. But at least one structure was visualized in close to 90%, which is great, and after dissection, almost in 97%. And that structure was a common bile duct, as I showed also in one of my videos. So when you see these, there is a lot of confidence that the main ductal areas have been identified. We also started doing this direct cholangiography because that indirect one or IV one requires pre-administration of this, whereas this you can do on the table. And this also shows these structures beautifully. And again, this can be visualized consistently. The problem is spillage, which will stain the tissues and you will not be able to visualize, or if the cystic duct is blocked. There's a Delphi consensus on ICG cholangiography, and the consensus there is, and there is a lot of literature and data also, that it appreciably enhances visualization of biliary structures, reduces overall surgical risks and risk for bile duct injury and conversion. It has several advantages over intraop cholangiogram, the conventional one, as I highlighted. The dose is a problem, but it is an absolute dose and usually 5 milligram or 10 milligram. And as I mentioned, various systems require various timing and dosage. There was no consensus in this Delphi survey on the optimum timing of administration and the dose. So that's the thing which is shortcoming in this. Just one small quick video. This is an acute cholecystitis. You can see a tense, edematous, distended gallbladder. And when you look in white light, you will not be seeing any vital structures. You would see a hepatoduodenal ligament, but no vital structures are visualized. And then on near infrared cholangiogram visualization, you can see that you can see fluorescence on the liver, and now you can see the common bile duct. So you know that this is the area which you have to be away, and this is the part where you have to dissect. And then once you proceed further, you should be able to visualize the cystic duct and so on and so forth. So in summary, I think near infrared fluorescence cholangiography is safe, non-radiating technique to identify the extrahepatic biliary anatomy. And my personal experience of a unit has shown that it is a very useful adjunct. It is, you can visualize the extrahepatic anatomy and increases the safety of laparoscopic cholecystectomy. The only caveat is what dose and at what time you administer. We usually administer in the morning, usually about 3 hours before the cholecystectomy. And these patients, when you're doing it, there is a good bile duct to liver ratio so as to visualize the extrahepatic biliary anatomy. Thank you very much.
Yeah, Monica? Dr. Monica? I think we've lost connection with her.
Right.
So any faculty member would like to make any comment? Anybody else has experience with ICG?
I think I just want to make one more point that the newer systems which are coming all have ICG enabled systems. So it will make it much more user friendly and many more people would probably adopt using this.
So since we just have 15 minutes and I don't see any question in the chat box from the audience, if there are any, we'll take them later. I'll quickly rush through this presentation. I will not go into the details of the, is my slide seen?
Yes.
Okay, so I will cover some important aspects of medical legal issues related to mainly bile duct injury. I think, Monica, we lost the connection with you. You want to make any comment? So cholecystectomy is a common reason for litigation. And this is data from US that during the open cholecystectomy era, over a period of 20 years, there were only 68 cases. But after that, the cholecystectomy related claims from 1995 to 2015, same 20-year period, there were 785 cases. And similarly, in the UK, in recent years, there have been several reports where a large number of cases were filed and claims were given. And the average number which they have calculated based on the denominator of the number of cholecystectomies is that about 4 to 7 out of 10,000 cholecystectomies in the UK resulted in a medico-legal complication for the surgeon. And in the cholecystectomy, in all reports, obviously, it is the bile duct injury which is responsible for the medico-legal case, ranging from 50 to 80% of cases. So there are other complications also which result in a medico-legal case being filed, but obviously bile duct injury is the commonest, whether it is data from the US or the UK. Now, the number of patients out of bile duct injuries who filed a medico-legal suit ranges from the low of 20% in Netherlands through 33% in UK, 37% in Italy, to as high as 70% in the US. So in the US, in one report, which was in 2014, 43 out of 62 patients with bile duct injury, and obviously because US is a very litigious society, we have no data from India. I have tried to look for some data, but I could not find any data from India. This is what information we have. And actually, most of the reports on medico-legal issues related to cholecystectomy and bile duct injury are from these three countries only. And when is a case filed? When the patient is young, when there is an associate, these are from different articles, associated vascular injury. Obviously, if it is a major bile duct injury, including a complete transaction, if the injury was missed during the operation and detected in the post-op period, if there was a delay in diagnosis, if it is recognized late and a late transfer to a higher center, and in most reports, attempt to repair by the injuring surgeon in the injuring hospital is a very important risk factor for a medico-legal case. Now, as far as the surgeons are concerned, when they were interviewed, 22% of 117 surgeons in Association of GI surgeons in the UK, they reported that they have had a medico-legal experience related to cholecystectomy. In our survey, which my colleague Dr. Supriya from SGPGI and we did, when we interviewed surgeons, they only 6% reported a medico-legal case who responded to our survey. And in fact, one author goes on to the risk of, to the extent of saying that if you want to minimize the risk of litigation after cholecystectomy, then you should be doing open rather than lap chole. Now, as far as claims are concerned, the claim rates are high in the UK to the tune of 60 to 80%. They are about 90% in Italy. They are much lower in the US, although in one report it went up to 86%. But the lowest reports of claims are in Netherlands, which is only 20%. Again, out of the cases which are filed, the risk factors for a claim being awarded by the court is complete transaction, again, repair by the injuring surgeon in the injuring hospital, delay in referral. As the period of or duration of referral increases, the claim rate increases. And obviously, if it is a CPD injury, then more claims were awarded, which is as high as 90% in one report, which is a review of 14 studies, including 2,400 bile duct injuries. The amount of compensation varies, and it is maximum in the US, $200,000 to $700,000. In the UK, it is in the range of $50,000 to $250,000. In Italy, it is less. And in Netherlands, I was also surprised. The compensation which was awarded was much lower. in the range of 12,000 US. And again, the amount of compensation in two reports increased with delay in imaging, delay in diagnosis, if a re-laparotomy was required, and if the repair was attempted in the injuring center, and obviously if the patient died as a consequence of bile duct injury. Now, when the surgeons were interviewed, it was found that poor communication of the bile duct injury to the patients and relatives was the cause of litigation. Again, in another report, in 75% of cases, there was inadequate information given to the patient or relatives. And the same is reflected in many other reports. And in one report, they said that there should be a nationalized, standardized list of lab coli consent form, which should mention the same complications, so that patient doesn't say that one surgeon says that my risk of complication is high and other says my risk of complication is low. I think our national societies, maybe we can take it up as a next initiative, that we approach them, that we should have a standardized consent form where the same risk of complications and problems are mentioned. This was an interesting study. When 207 surgeons were interviewed, they were asked that, do you mention any of these 9 complications? So only 3 out of 9 of these complications were mentioned more than 50% of the time. And bile duct injury was never mentioned by 25% of surgeons and rarely mentioned by 22% of surgeons. So although it is the most dreaded complication, which can become a complication for the surgeon also, as many as 50% of the 207 surgeons who were interviewed in the UK accepted that they did not make a mention of bile duct injury in the consent form. But if a case is filed against you, what protects you, or what makes the court of law or the consumer forum decide the case in your favor, are some of these factors. Proper structured training, if you can show that you are well trained, if you have taken a good, detailed, informed written consent, as I mentioned, mentioning all possible complications and preferably their incidence. If you have a high index of suspicion, which means that you have a low threshold for investigation in case patient doesn't do well in the post-operative period, rather than just discharging the patient home or sitting over the patient, giving complete information about what has happened to the patient and relatives, appropriate management if it is possible in your hospital, which includes interventional radiology and therapeutic endoscopy. And if it is not there, then timely referral to what I call a biliary center where these facilities are available, with a detailed referral note, preferably a personal communication with the doctor who is going to receive the patient in the biliary center, and proper documentation of all events, including pre-operative, intraoperative, and post-operative findings. So if you do all this, even if a case is filed against you, the chances are that the case will be decided in your favor. And as is true in most situations, most litigations are because of poor communication with the patient and relatives. And in one study, the postgraduates were given 2 hypothetical scenarios, that you communicate a bile duct injury to the patient or relatives, and you communicate the occurrence of an incidental gallbladder cancer to the patient or relatives. And most residents poorly fared when they were asked to communicate a hypothetical bile duct injury to a patient as compared to an incidental gallbladder cancer. And again, most of the claims were because of poor documentation of what happened and what was done. So finally, is bile duct injury a complication or an adverse event of a procedure? Or is it a mishap or an error or a mistake to the tune of negligence on the part of the surgeon? When experts were interviewed and they were given 10 cases of for bile duct injury to give their opinion, it was found that in only one case, all of them agreed and gave the same opinion. And in as many as 7 out of 10 cases, only half of them agreed. So which means that even experts do not know whether it should be considered as a complication, which is inherent in a procedure, or whether it is a mistake or negligence. And in the Netherlands, the incidence of accepted claims, which means decided in favor of patient has decreased from 15 to 18%, probably because most experts now feel that bile duct injury is an inherent complication of the procedure. And in Germany, in the earlier era, the attitude was that a bile duct injury indicates below the expected standard of care, whereas later on in 2004 to 2009, most experts said that it is an inherent complication of the procedure. So what I have said in one of my publications, just as there is a difference between a homicide, which is intentional, and a culpable homicide, which is unintentional, and where the punishment also is less. Similarly, in my opinion, a bile duct injury is a culpable choledococide. The bile duct has been injured or has been murdered, so to say, within inverted comma, but it is not intentional, and in all cases, it does not amount to negligence. And those are the factors which, if I am called as an expert to give an opinion on a case of a bile duct injury, I will consider those factors before I give my decision whether it was intentional or it was unintentional bile duct injury. So this is one article which was published a couple of more 7 years ago, in which I covered the medical legal aspects of bile duct injury. Those of you who want to go through this is available free on the internet. And there are a few more publications after this article, which I tried to cover in the presentation. So before we finish, I would once again like to announce that this activity was conducted under the auspices of Jaipur Surgical Tutorial, which is being managed by my colleague, Dr. Anand Nagar, who unfortunately had to leave in between to see a patient in the liver transplant ICU. Because he's an active member of our liver transplant team. Those of you who want to join JST, please WhatsApp Dr. Anand Nagar at this number. As I said in the beginning, we have a session every Saturday, 9 to 10 India time morning. And we will now be conducting these master classes regularly on last Thursday and Friday of the month, 7 to 9 p.m. both days. And the next master class will be last Thursday and Friday of August. And the topic is going to be chronic pancreatitis. Yesterday, somebody suggested or requested a masterclass on acute pancreatitis. We'll do that in the month of September. So over to you, Sadiq, for any concluding.
There's one question for you.
Yes.
Who on the chat box, if you could see.
I'll take it.
Yeah.
Who is liable to bear the cost of further treatment in case of bile duct injury, medico-legally, if an informed consent has been taken for risk of bile duct injury? I don't think that question has been addressed. I don't think a surgeon should be asked to bear the cost of treatment of a complication, because that will open a Pandora's box for all complications, including mortality. So it is up to the consumer forum to award a compensation, which may consider the cost of further treatment. I know many surgeons in real life practice do it, that when they take a patient to a biliary center, they say that they will bear the cost of treatment, but I don't think that can be recommended on a scientific forum. We have 2 minutes. Sadiq, any closing remarks?
No, I mean, I think I have thoroughly enjoyed this 2 days.
There is another comment from a surgeon from Myanmar. Maybe I will just read it out. This is Dr. Professor Mo Mint. He's a very senior surgeon in Myanmar. He says in Myanmar, hepaticojejunostomy is the preferred procedure for major bile duct injury. From medico-legal point of view, who should perform Roux-en-Y hepaticojejunostomy, the repair procedure? I have a very standard answer to this. All bile duct injuries must be repaired by a biliary surgeon in a biliary center. And who is a biliary surgeon? A biliary surgeon is one who performs a biliary enteric anastomosis, say after PD, say after choledochal cyst excision, say after cholangiocarcinoma excision, on an elective basis as a routine, not once in a blue moon. He or she is a biliary surgeon, and bile duct injury repair should be done by a biliary surgeon. It should not be attempted by a non-biliary general laparoscopic surgeon. And timing of hepaticojejunostomy, Dr. Mint, that is a big question, big debate, which I don't think can be covered in a couple of minutes.
Sir, can I take
yes.
a comment, please?
Yes, Ajay. Ajay, yes, please.
Yeah.
Ajay, your signal is very poor. We are not.
to see that.
I think Ajay is still traveling, so his signal is poor. Sadiq, you please go ahead.
So I must, I mean, I thoroughly enjoyed this 2 days, and I really appreciate all those who have taken time to attend this, and I'm sure they benefited in some manner or the other. A big thank you to you, Dr. Kapoor, for accepting this suggestion and conducting this and giving us an opportunity to participate in this GST. I need 100% track record in GST. So 1, 2 gone, and hopefully in all next months, there will be a place for me. And I think at the end of the day, I can only say that we can do our best, both in making these sessions fruitful for people who attend, and if any other issues or comments or questions which are required to be addressed, they could address to each one of us individually, and we would be happy to interact with them. Thank you very much once again.
So it's 9:01.
Sir, one,
yes,
yes, sir,
TD.
one small, just last this thing, I was looking at this thing after seeing your talk. So there is a very good publication from in Null Subsurgery 2019. And I have just send you take the first page and shared in the GST. So this is by the Lilimo group. So that can be shared with everybody and they can see, go and read this also in whatever you told, other than the same thing has been addressed very nicely. And as sir said, yesterday I could not join because I was returning from Jodhpur and reached late home. So I missed a lot, but thank you for starting this and continuing with that and allowing us to participate and enjoy and learn so many things from each other. Thank you.
So thank you all the participants for attending. Thank you all the faculty. I can still see KJ there, Dr. Shalu there, Dr. Monica, Dr. Anu Bihari. Thank you everyone. Thank you our special guests from abroad, including a large contingent from Myanmar. And as I said earlier, we hope that Jaipur Surgical Tutorial and all the GI surgeons in the country would be very happy to have more academic collaboration with surgeons in the SAARC countries. Thank you all very much. We will. And before I forget, I would like to, I have already been mentioning Anand's name. He is the man behind the GST. And Dr. Avinash Tank, who is again an SGPGI alumnus, who is in Ahmedabad. He and his team of Himanshi and Kripa have been offering technical support, not only for the master. Thank you.
Thank you, sir.
Thank you. Thank you for coming in. And for all the GST activities, including the master classes, they immediately put all the recorded videos on YouTube channel of Jaipur Surgical Tutorial. And I have to mention one of my students, Harshil, who has been creating all the WhatsApp groups and doing the technical part for these activities. So with that,